So good evening everyone. If I'm visible and audible, please give me a thumbs up. I haven't got a message from anyone. So I can see students having joined the session. Yeah. Yeah, so I got one message. Hi. Good evening. Good evening. So if I'm visible and audible clearly, so I'll start with the session. Dr. Me being myself, D4T, okay? And Dr. Navilia T3. Chalo, I think everyone can hear me. So let me start with the session. So anyways, as you must have gone through the previous sessions also, this is a video-based question series. Today we'll be discussing the questions from anesthesia that can become, that can come as a video-based questions. Previously, this series has been started because there were questions that have come in the FMG exam, which all of you are aware, which were video-based questions. There was a question from anesthesia also. So similarly, there are few questions that we have set up, few videos which have come from anesthesia. There are a lot of questions which can be set up actually from anesthesia also, because there are a lot of procedures involved and these procedures are easy and you're supposed to know them as well. So based on that, let's start with the session. We'll be discussing with anesthesia. A lot of people have joined, and as I always say, I like the interactive sessions. So we will be having the interactive sessions. I am sharing my Instagram ID, my WhatsApp number. You can have any questions and doubts directly telling me, or you can ask me questions based on that. All right. So let me go forward with the first question. Right. So here is the first video. Right. Go through that. When I'm asking the question, I will show you the videos again. Here's the first video that you can see. All right. Based on this video, we'll be having a question. Yes. So I'll play it again. All right. I'll play it again. Okay. So based on this, we will have the first question. You must have understood what question this is based upon. Okay. So I think all of you have seen this. Going forward, so this is basically the first question, video-based question. 24-year-old patient is planned for laparoscopic removal. All right, laparoscopic removal of gallbladder. The video is showing a clinical airway examination being conducted during the pre-anesthetic checkup. Right, the patient is classified into which grade based on the examination video. The options that we have is Cormac-Lehan grade 2, Cormac-Lehan grade 1, Mallampati grade 1 and Mallampati grade 2. I'll show you the video again right here itself so that you can just see and try to guess as to what the answer is. Not guess, but yeah, what it is. So I'm showing you this image again, the same video. So a lot of students have mentioned here Mallampati grade 2, stage 1, Mallampati score 2, Mallampati type 1. So I think Dr. Ankit Mahajan 65, Dr. Pawan Teja, they have said Mallampati grade 2. This is yes, Mallampati grade 2. Correct. Tip of the uvula not seen. Absolutely correct. So this was not a very easy one. Here you had to know the Mallampati. This is Mallampati grade 2. Let me show you the video again. Right. If you will see the video, the tip of the uvula is not seen. So when you do a Mallampati examination, you ask the patient to open the mouth, extend the tongue, do not phonate. And if you can see here, the tip of the uvula is not visible. Tip of the uvula is not visible. So if the tip of the uvula is not visible, it is not Mallampati 1. So this can be Mallampati 2 and Mallampati 3, right? And of course it can be Mallampati 4. But the point is you can see some part of the uvula. So Mallampati 4 is again out. So your point now is between Mallampati 2 and Mallampati 3, right? So if we go back again, if you will see the video. So if you can see, it's just not the base, but you can see this part of the uvula also. All right. Even this part of the uvula is visible. It's just that the tip of the uvula is not visible. All right. So therefore, this is basically Mallampati grade 2. I think all of you agree with me, right? So dark inside, yes, but that is how it is, guys. That is how the questions will come in the exam if it is, because this is exactly the best that we can do in terms of examination. If you will see, you can still see here the tip of the uvula is not visible. This is exactly how the examination gets done. All right, Dr. Dost XYZ said, right? This is exactly how it does. Okay, this is exactly how it is. Okay, agreed. It might be slightly difficult. I totally agree with you. But if you see the examination, especially if you're seeing it, that is exactly why it is not Mallampati 1. Had it been Mallampati 1, you would be able to see the uvula very clearly. It will be clearly seen like this. But because here you cannot see it, right? The tip of the uvula is not visible. So here what you can see is basically, here this is the end of the video. If you will see the in-between video, na? If you see something like this, wait. If I'm playing it again, if you look at this here, एक second, just give me a second when we are playing the video. Okay. Right, there you go. So if you look here, it is seen half of the tonsillar pillars, half of the fauces, and tip of the uvula not visible, right? So this is Mallampati grade 2. Now, when we are discussing Mallampati, guys, all of you know it's a very important question in the exam, right? Everyone is aware about it. So when we speak of Mallampati grading, remember we have it Mallampati 1, Mallampati 2, Mallampati 3 and 4. Now, all the things, all you do is ask the patient to open the mouth, extend the tongue and do not phonate. Open the mouth, extend the tongue and do not phonate. Right? This is a basic. Now, when you look at all the structures and you can see the complete uvula, you can see the complete tonsillar pillars, you can see it complete fauces, you can see the soft palate and hard palate, that is Mallampati 1. When the tip of the uvula is not visible, that becomes Mallampati 2. Half tonsillar pillars, half fauces, but soft palate, hard palate can be seen, Mallampati 2. Mallampati 3, only the base of the uvula is seen, but no tonsillar pillars, no fauces, but you can see soft palate, hard palate. Mallampati 4, nothing is seen except for the hard palate. Point is, Mallampati classification correlates with the Cormack-Lihan grading. Now, Cormack-Lihan grading is the laryngoscopic grading. This Cormack-Lihan grading is what is called as the laryngoscopic grading of the vocal cords. In Mallampati, I am looking at the uvula. In Cormack-Lihan grading, I am looking at the vocal cords. So this is Cormack-Lihan 1, Cormack-Lihan 2, Cormack-Lihan 3 and Cormack-Lihan 4. So Cormack-Lihan 1, you will find vocal cords seen. Cormack-Lihan 2, half vocal cords seen. Cormack-Lihan 3, OP, only epiglottis seen. Cormack-Lihan 4, nothing is seen. And therefore, right, we will find that this is a vocal cord based grading. You will find that wherever uvula is visible, you are going to find vocal cords being visible. And that is the reason why Mallampati 1 and 2, you find vocal cords seen. That is why they turn out to be easy intubation. Mallampati 3 and 4, vocal cords not seen because of Cormack-Lihan grading. They turn out to be difficult intubation. Clear, everyone? Right? Everyone clear? Okay, just give me a second, guys. Just give me a second. Okay, let's go to the next question. All right, let's go to the next one. So this was the first question. Any questions and doubts, guys, you can ask me. Otherwise, we'll go to the next one. All right, here is the second question. Go through the video and then we'll ask the question. Okay, here's the video. Right, everyone gone through it? All right, so this is the second video. Now we'll just see the question based on this. All right, I'll play the video again. This is the second video that we have. Okay, I'll play it again. There we go. Just look at it. All right. So in anesthesia, such questions, correct. So Dr. Anuj Kumar Chaudhary has already given an answer without me asking a question. He was able to identify, and of course, that is what is going to be the question. Very nice, Dr. Anuj Kumar Chaudhary. That is exactly how these questions can be expected for you to identify what it is, right? Clear? So this is basically a monitor on which a question has been asked. Okay, so let me go and ask the question on this. There we go. So as soon as the patient enters the OT, monitors are attached to the patient. Identify the monitor shown in the video. Is it a neuromuscular monitor? Is it a bispectral index? Is it a reflectance pulse oximeter or a capnography? All right. So this is the video, and here is what we can see. Correct. So therefore, Dr. Anuj Kumar Chaudhary has given absolutely correct answer, and this is bispectral index or BIS monitoring. Absolutely correct. That is the answer. Okay. So previously was Mallampati class 2. Here the answer is bispectral index. The answer is B. Dr. Ankit Mahajan, Dr. Gaurav and Dr. Sparkle Shine. Everyone has given answer B. Dr. Avdesh Deshmukh. Correct. All of you are correct. It's a bispectral index. Okay. Bispectral index. Now, Dr. Roshni Justice also says B. Correct. B is the answer. So therefore, it's a simple question. How did we identify? We have identified it because in this question, what we have done is we are looking at the monitor which has been attached at the forehead, right? You are seeing this monitor which is electrodes which are attached on the forehead. So whenever you have these electrodes on the forehead, it means ideally you are doing a EEG monitoring. Electrodes on the forehead. Okay, so when you have these electrodes on the forehead, basically these electrodes on the forehead are going to monitor the electroencephalogram, and based on the electroencephalogram, you have the bispectral index. This bispectral index is basically a monitor which tells you about the patient being conscious or unconscious, awareness during anesthesia. So this gives you numerical value between 100 to 0. So if a patient is awake, it will give you a value of 100. If a patient is deep into coma, it has a flat line EEG, the answer will come as 0. So when you're giving general anesthesia, a value of 40 to 60 is what is said for GA. A value of 60 to 80 is what is said for sedation. So bispectral index basically tells us about the consciousness of the patient. It is basically talking about the brain activity of the patient. So everyone has said correct. It tells you the depth of anesthesia. So exactly that point I'm coming to. So when we are speaking about the bispectral index, the advantages of bispectral index is that it is basically telling you the depth of anesthesia. How deep is the patient under anesthesia, whether the patient is sedated or whether the patient is under GA or if the patient is awake. So you come to know this. Based on that, you can titrate the dose of anesthetic agents, right? This would help for a faster recovery, less complications because you are titrating the drugs correctly. So therefore, it leads to less complications, right? And faster recovery, faster emergence from anesthesia. And at the same time, it prevents awareness during anesthesia. Right? So these are the advantages of using the bispectral index. Now, when we speak about the other monitors over here, neuromuscular monitor, always remember when you have a neuromuscular monitor, there has to be a nerve and there has to be a muscle. So that is exactly why you'll be looking at a neuromuscular monitor. And most common that is used is, if you remember, is the ulnar nerve and the adductor pollicis muscle. Adductor pollicis muscle. All right. Reflectance pulse oximeter is what we are wearing in our watches. It reflects it. It is not going through and through. What you wear in Apple Watch, you know, any watch that you are wearing, that is the reflectance pulse oximeter. And capnography is the graph of capnograph, which will be seen like this. Remember, capnography itself is a big question by itself. Okay. It can be a question, image-based question by itself. All right. Okay, so that's about the second. Any questions and doubts, guys, you can ask me. This was about the second video, which was regarding the bispectral index and the type of monitors. Let's go to the third. If there's any question and doubt, guys, you can ask me. The third video is here right now. Let's see this. Okay, you can see a video here right in front of you. Okay, so I'll play this again. So look at the video. Hopefully few things will be clear. I'll play it again. There we go. All right, then we'll ask the question and we'll play the video again. All right. So now you have seen two cylinders, right? You have seen two cylinders. So the cylinders are attached on the anesthesia machine as shown in the video. The pin index numbers of both the cylinders, first regarding the left cylinder, followed by the right cylinder respectively, are 2, 5 and 7, 2, 6 and 7, 2, 5, 3, 5 or 3, 5, 2, 5. This is basically a question based on the pin index numbers of the cylinder. So we have a cylinder, the video of the cylinders, you can see two cylinders. This is the first cylinder which you see over here. This one, here is the second cylinder. This is the second cylinder, right? And the first cylinder is over here. So I think you guys need to know the pin index number. No, you need to know the pin index number of the first and the second cylinder. For that, you need to identify them. All of you know what are the cylinders. The first cylinder that you can see is oxygen. The second that you can see is nitrous oxide. So you are supposed to know the pin index numbers of these two cylinders. So oxygen pin index is basically 2.5 and nitrous pin index is 3.5. So therefore the correct answer is option C as suggested by all of you. All of you have given me the correct answer. Dr. Gaurav started with saying that, oxygen nitrous pin index. Dr. Sneha Das says C, Dr. Ankit Mahajan, Dr. Vayu. Okay, everyone has given the correct answer. Okay, so this is 2, 5 and 3, 5. That's the correct answer. So when we are discussing the pin index numbers, so remember the three important ones are air. The pin index is 1.5. When you speak of oxygen, it is 2.5. When you speak of nitrous oxide, it is 3.5. These are the three most important. That single number was for Entonox, which is number 7. And when you speak of carbon dioxide, depending on the percentage of carbon dioxide, it can be 1.6 or 2.6, right? And apart from that, the colors are important. So oxygen is always black with white, as you could see right now, black with white shoulder. Nitrous oxide is always blue in color. Entonox is a combination of oxygen nitrous. So therefore, it becomes blue with white, right? Carbon dioxide is plain simple gray. And the last one is air that you need to remember, which is gray with black and white shoulder. So these are the colors and the pin index numbers. Correct? So I think everyone has given a correct answer over here. Let me go to the next video. If there's any question or doubt, guys, any doubts that you have, please ask me. Okay. So here is the next video. I think here no doubts na, from anyone. Let me go to the next one. Here is the next video. This is our fourth question. You can see something over here. Let's play the video. Okay. As I said, from anesthesia, this is the questions that I thought could have been asked from various parts of anesthesia, right? Which are important, which are relevant, and all these have been asked in the exam. They are all based on PYQs. I'll play this video again. All right. I'll play this video again. There you go. Okay, so I think you have seen this video, and let me, Dr. Anuj Kumar Chaudhary knows the answer, and therefore this is exactly how the question should be asked. A vaporizer with electrical circuit is being filled up with an inhalational anesthetic agent as shown in the video. Which is this inhalational anesthetic agent? Halothane, sevoflurane, desflurane, isoflurane. Yes. So Dr. Anuj Kumar Chaudhary says Tech 6, and Dr. Gaurav says desflurane, Dr. Sneha Das says desflurane. Absolutely correct. The answer is desflurane because it has this electrical supply. Right? This is one question, is a PYQ. It has been asked many times in the exam, and this is through a video, the same question we've asked over here. All right. So the same PYQ, PYTs, but now in a video format. That's the whole form, right? Whole the point about it. All right. So this is desflurane. So when you speak about the vaporizers in anesthesia, remember desflurane is the one which has the electrical circuit because it boils at 23 degrees. So therefore, having the electrical circuit, it needs a special vaporizer, and this special vaporizer, what you can see, is called Tech 6. It's blue in color. So when you speak of vaporizer colors, remember halothane vaporizer is always red in color. Isoflurane vaporizer is purple in color. All right. Enflurane, which is not anymore used, enflurane, that is orange in color. It is not used, so I think we can forget it out. Desflurane is what you saw right now, blue in color. And sevoflurane is yellow in color. Out of this, the desflurane which you saw has a different structure. This has a special vaporizer, which you can see. which has an electrical supply. No other one has an electrical supply. This needs supplied heat. It needs supplied heat. It has an electrical supply. This is basically electrically heated. What's the reason behind it? Because desflurane that you see, it boils at 23 degree or room temperature. And that is why we have this special vaporizer for desflurane, which all of you have mentioned as Tech 6. Absolutely correct. So this is desflurane. Okay. So this was the fourth question that we saw. Right. Any other questions and doubts you can ask me? All right. It's a short session basically, guys. So we are just discussing the videos and the points from here so that you are aware as to what questions can come from anesthesia. This is the fourth one. Right. Fifth one. You can see a fifth question now. And this is the video. All right. You can see this hopefully clearly. I'll play it again. All right, here we go. So in all these videos, you should be able to identify as to what is happening. All right, I haven't asked the question yet. Now you've seen the video. Let's see the question. A 29-year-old female patient is undergoing hysteroscopy for polyp removal under general anesthesia. The video shows an intravenous induction drug being administered to the patient. So you have to understand what drug it is. Which of the following is a common adverse effect associated with the use of this agent that is patient is getting? Is it nausea, vomiting? Is it hepatotoxicity, increased intracranial pressure, or hypotension? So you need to see exactly what is going to the patient. So here the drug that is going, Dr. Anuj Kumar says Propofol. Absolutely correct. This drug is a white colored fluid which is going white colored, and this is Propofol. What is going is Propofol. All right. Propofol IV anesthesia. But that's not the question. You've identified Propofol correct. But the question here is which of the following is a common adverse effect associated with the use of this agent? Right. So is it nausea, vomiting? Is it hepatotoxicity? Is it increased intracranial pressure or hypotension? We are asking a question which is this has been asked in the exam, the same. It's a PYQ, and I've just twisted the points to ask here over here. Okay. So, all right. This basically, is it nausea, vomiting? So everyone has mentioned ICP, and what answers I've got? I've got only ICP. D says Dr. Vidyanand. Dr. Vayu says hypotension. Correct. Answer is hypotension. Absolutely correct. The answer is hypotension. When you speak of nausea, vomiting, it's not the answer because Propofol is an agent that has anti-emetic properties. Hepatotoxicity, no, it gets 70% metabolized in the liver and 30% metabolized in the lungs. Right? Increased intracranial pressure, no, it decreases everything. It is a cerebroprotective agent. So therefore, the only thing that it causes is hypotension that we have to be worried. This is the only place that you have to be careful. So therefore, Propofol, if you ask me actual contraindication of Propofol, is a patient who is in shock and who has got hypotension. That is the only contraindication. Otherwise, Propofol does not have any contraindication. In fact, the other points are, so Dr. Anuj says Propofol infusion surgery. But the Propofol is being getting to the patient. That's what patient is getting. The other points about it that you can see is that Propofol has anti-emetic properties. Okay, it has anti-emetic properties. It has anti-pruritic properties. Right, it has antioxidant properties. These are all properties of Propofol. When we speak of metabolism of Propofol, it is different from other agents of IV. It is getting 70% metabolized in the liver plus 30% getting metabolized in the lungs. And that's the reason it's getting metabolized from two places. It undergoes absolutely rapid metabolism. All right. And therefore, it has a very, very fast recovery. The elimination T half means the time for the drug to become half is just 1 to 2 hours. And that's exactly why this Propofol is the drug of choice for daycare surgery. In fact, it is very good for a liver patient because you also have lungs from where it gets metabolized. It's getting metabolized from the lungs also. Therefore, if a patient is a liver patient or a patient is undergoing liver surgery, because only the liver is not dependent on metabolism. It's a good agent for liver patients. It is not producing hepatotoxicity. Regarding the pharmacodynamic properties, all right, pharmacodynamic properties regarding the CVS, regarding the RS, and regarding the CNS. So everywhere it produces considerable depression. In the CVS, it decreases the blood pressure, it decreases the heart rate, also decreases cardiac output. In the respiratory system, it causes absolutely respiratory depression leading to apnea. And in CNS, it decreases intracranial pressure, decreases cerebral blood flow, decreases cerebral metabolic rate, and it is anticonvulsant. And therefore, just like thiopentone, even propofol is called as a neuroprotective or a cerebroprotective agent. Upon that, even ophthal, if you will see, it produces a decrease in the intraocular pressure. So it is kind of decreasing everything. So here you will find increased intracranial pressure is not the answer, right? It does not increase anything. No nausea, vomiting, no hepatotoxicity, no increased intracranial pressure. The only answer is hypotension. Dr. Anush Kumar says, sir, is it the agent of choice for daycare? Exactly. I gave you the reasons behind it. All right. I gave you the reasons also why it is a drug of choice for daycare surgery. All right. Fast recovery, pleasant recovery, fast elimination THAF, rapid metabolism, and out of the body. Okay. So absolutely correct, Dr. Anuj Kumar Chaudhary. Next question. So we are coming to question number 6. Now go through this video, right? And based on that, I'll show the video again. We'll ask one question based on, okay? You can see something. All right. I'll play this video again. Let me go back. Let's play this video again, right? There we go. Okay, you can see something. There's a clinical sign that you can see. All right. And based on the clinical sign, I'm asking a question, right? I think you've seen the video, all of you. So this is the question over here. The clinical finding shown in the video is seen immediately within 15 seconds of administering a skeletal muscle relaxant to 55-year-old patient undergoing emergency surgery for intestinal obstruction. This finding is seen with which of the following skeletal muscle relaxant? So I'm playing this again. You can see this video. So is it succinylcholine? Is it rocuronium? Is it atracurium or vecuronium? Yes. Dr. Y has given an answer. Dr. KKB has given an answer. Right? Okay. Dr. Sneha Das has given an answer. Good. Right? Which means you're aware as to what the question has been. So this is a clinical sign that you've got. Within 15 seconds of administering a skeletal muscle relaxant, this exactly is what is called as fasciculations. So that is the answer is succinylcholine. With succinylcholine, you get to see fasciculation. It is the only depolarizing muscle relaxant. The other three that we are talking about are non-depolarizing, and succinylcholine basically is a depolarizing. So because it undergoes depolarization, therefore it is going to produce some muscle movement, which is called as fasciculation. So these are fasciculations which are seen after giving succinylcholine. All right. Okay. So remember, when we speak of skeletal muscle relaxants, these are of two types: depolarizing and non-depolarizing. There's only one depolarizing, which is succinylcholine. All others that we talk about, vecuronium, atracurium, pancuronium, mivacurium, are all non-depolarizing. All of them. Depolarizing means they undergo depolarization because they are agonist at the receptor. These drugs are antagonist at the receptor. Because they are agonist at the receptor, these drugs are working like acetylcholine and therefore they undergoes depolarization. These drugs work as antagonists at the receptor, therefore they undergo no depolarization. Because they don't undergo depolarization, that is exactly why it is called as non-depolarizing. Reason is that these are competitive antagonists at the receptor. They compete with what? They compete with acetylcholine. Right? On the other hand, depolarizing agents are non-competitive to acetylcholine. That is why they work like acetylcholine. Okay. So because they work like acetylcholine, they cause depolarization. Because of depolarization, you're going to get some muscle movement, and that muscle movement that you get because of depolarization is what is called as fasciculation. And therefore, because here there is no depolarization, therefore there is no fasciculation. So what you just saw in the video is fasciculation. All right. And correctly said by Dr. KKB that, this is going to produce post-op myalgia, and that becomes one of the side effects. Correct. The fasciculation basically is going to increase all the pressures. The fasciculation produces post-operative myalgia. Absolutely correct. It may even produce muscle damage leading to myoglobinuria. All right. So all the increase in pressures, intracranial pressure, intraocular pressure, intragastric pressure, all is because of fasciculation that you get post-op myalgia. Okay. So this is because of the fasciculations with succinylcholine, right? So hopefully this point is clear to everyone. This answer here is not rocuronium, atracurium or vecuronium. The answer is succinylcholine, depolarizing muscle relaxant, and what we got to see is fasciculations. Okay. This is question number 6. Right. So if you can see the questions, the videos from anesthesia are from length and breadth of anesthesia. It is not just about Mallampati examination. We saw the anesthesia machine, we saw the cylinders, we saw the vaporizer, we saw the induction agent, Propofol, we saw the muscle relaxant. Let's go to another question, right, from all different topics. Go through this video and we'll ask the question based on that. Okay. So just look at what drugs are there. Okay. You saw one agent over here. You saw another agent over here right now. You can see this agent over here right now. Okay. Just go through this video, right? So if you will see now in this video what is happening. So from bigger vial, which you can see, something is aspirated. Right. So you have seen what is the bigger vial, and now you can see in the smaller vial, it is being injected. This is the video version of a PYQ which has been asked in the exam. Okay. This is the video version of PYQ. Okay. Clear? So I'll play this again and then we'll ask the question based on this. All right. So that you can just see it again. Let me go back. We'll play it again. Can you see this? Here is one agent that you can see, and here's going to be another agent that you see. Let me play it. So here is the first and the second agent. So, all right. So one agent has been added to the other. Dr. Anuj has already given the answer. Dr. Anuj, let me give you the options and then you say, okay, then we'll see. Okay. So something has been taken from the bigger vial, added to the smaller vial. Okay. And all the names are clearly visible as you can see. So let me ask the question then. It has been added over here. There we go. The video shows a small amount of additive from the first vial, which is bigger in size, as you can see, first vial, being added to the drug in the small ampule. Which of the following best explains the reason to do so? Faster onset of action of the drug in the small ampule. It prolongs the duration of action of the drug in the small ampule. It decreases the bleeding during the surgery, or it reduces the toxicity of the drug in the small ampule. Yes, guys. So answer A, B, C, or D. Yes, there are so many of you online. Yes, I can see so many of you. Answers, guys. I'll play this again. Let me play now. In the small one also, you can see what is being done. So I've got an answer. Options I'm getting one by one. So you can see what is happening. All right, that is where we get confused. So I think the only person that I got giving a correct answer till now is Dr. KKB, and this is faster onset of action in the small ampule. Remember, all of you have studied and you're talking duration of action. This is not with soda bicarb. This is with adrenaline. Remember, there are two things which are added normally on which questions come. You add soda bicarb and you can add adrenaline. Here it is the addition of soda bicarb and not adrenaline. When soda bicarb is added, it leads to a faster onset, not a longer duration. A longer duration happens because of addition of adrenaline. So these 3 points are related to the addition of adrenaline. But when we are speaking of soda bicarb, as you can see from the video, that's why I told you, see the video. This is soda bicarb which has been added. So you are adding soda bicarb to lignocaine. All right. So addition of soda bicarb to the local anesthetic drug. Remember what is happening when we are discussing this topic out. This is regarding soda bicarb. This is the answer with soda bicarb. Okay. So the first vial was soda bicarb and the smaller ampule was lignocaine, local anesthetic. So therefore, why do we add soda bicarb to lignocaine? Remember, when we speak of local anesthetics, local anesthetic drugs are weak bases. You have weak basis. When you study pharmacology, you know a basic drug works in basic medium, acidic drug works in acidic medium. All right. So local anesthesia drugs are weak bases. So therefore, if you want a better effect, therefore add soda bicarb. By addition of soda bicarb, what will happen? This is a basic drug. So you get a basic drug in basic medium. Therefore, you get better effect. Right? You get better effect. Second point, it also causes faster onset. And third thing, it decreases the subcutaneous pain. And these 3 points have been asked in the exam as the question. Why you add soda bicarb? These are the 3 important reasons why we add soda bicarb. Better effect, faster onset and decreased subcutaneous pain. On the other hand, why do we add adrenaline? Remember adrenaline. So here we discussed the first point about local anesthetic drugs, that local anesthesia drugs are basically weak bases. All right. So these are weak bases. Apart from that, there's another property of local anesthetic drugs, that local anesthesia drugs are local anesthetics are local vasodilators. These are local vasodilator. They have an inherent property, except for one drug, that is cocaine. Except for cocaine. Remember cocaine, CO, that is a vasoconstrictor. Apart from cocaine, all other drugs are vasodilators. So therefore, what happens is when you're injecting the local anesthetic drug inside the tissue, right? So there are two things. Now, one thing happens that the drug works, has its effect on the nerve. Where the drug effect takes place, it gets divided in 2 parts, right? Effect takes place on the nerve, and of course on the second hand there is absorption by the blood vessel. Absorption by the blood vessel. Now my drug is a vasodilator. So if it's a vasodilator, what will happen? The blood vessels will dilate. So when you inject a local anesthetic into the tissue, the blood vessels dilate. Therefore, what happens is because of the blood vessel being dilated, absorption in the blood vessel increases, effect on the nerve decreases. Therefore, what we do is we add adrenaline or vasoconstrictor. By addition of vasoconstrictor, what will happen is the blood vessels would constrict, right? Because of this, the blood vessels are going to constrict. So if the blood vessels are constricted, there is less amount of drug in the blood vessel and effect on the nerve increases. Therefore, because effect on the nerve increases, you get a longer duration of action. Because the drug decreases in the blood vessels, you get decreased toxicity. Because there is blood vessel getting constricted, there is less bleeding that takes place because of the vasoconstriction that takes place. And all these 3 properties that you are seeing are with the addition of adrenaline and not soda bicarb. Clear? So prolongs the duration of action, decreases bleeding during surgery, reduces toxicity of the drug. These are properties of ADR. Thumbs up. Clear, everyone? Yes? Well, thumbs up, guys. I'm looking at all these messages, but I'm not getting any messages from anyone. All okay? Okay, let me go forward. I haven't got a message now. I'm looking at two places for messages. All right, let me go to the next question then. question number 8. All right, let's take question number 8. This is question number 7. Hopefully no doubts. Everyone okay? Here is question number 8. Kahan gaya? There. Okay. All right, so here you're seeing a procedure being done. All right, again, this is based on a PYQ. Okay, thank you, Dr. Anuj. Thank you. Dr. Anuj says crystal clear ho gaya concept. Good, thank you. That makes us feel good. All right, so epidural needle. Dr. Anuj already gives the answer which I wanted to ask. Okay, so all of you have understood this is a question related to epidural, correct? So during this procedure shown in the video, which special type of needle, okay, which special type of needle is commonly used to facilitate the smooth insertion and redirection of the catheter passed through it? Is it a Veress needle? Is it a Tuhi needle? Is it a Dura separating Whittaker needle or a Dura cutting Quincke needle? All right, so yes, what's the answer? Dr. Anuj Kumar Chaudhary, initially he saw that and he's mentioned. Dr. Ankit says epidural, yes. So all of you are giving the correct answer because yes, all of you are well prepared for the exam. Absolutely correct. This is a PYQ, but a video based PYQ now. Okay, video based, Tuhi needle. Remember, here they can ask you so many questions. It's not just about the, if I play the video, remember epidural, when we are saying, they can ask you questions about various layers getting pierced. They can ask you about this epidural needle. They can ask you about this catheter, right? They can ask you about the contraindications. They can ask you about the complications. So remember, just one procedure, it's the same thing. All you need to do is to identify the procedure, and based on that, the same question will be asked in the exam if it's a video based question. But you need to know what procedure is being done, right? The same question could have been asked, what is the last layer in this procedure that gets pierced, right? This is going to be ligamentum flavum. So I could have asked the same question again, right? Maybe the next time we are making a video based question, we can put away these options and we can ask the next part as to which is the last layer getting pierced, and it can become whether you're piercing, the last layer getting pierced is dura, or it is arachnoid, or it is ligamentum flavum, or it is posterior longitudinal ligament, right? The same thing becomes changed. A new question here only on the same video. And that's exactly how questions come in the exam. And that's why we say the PYTs are so important. It's not about the PYQ because the topic remains the same. But if you change the option, it becomes PYT. You're supposed to know those topics. Okay, clear? So here what we had asked in this kind, right? So here the answer is basically Tuhi needle. So when you say Veress needle, this is basically used for surgery, right? Laparoscopy surgery. All right, Tuhi needle is what is called as the epidural needle. As you can see, this needle basically has 1 centimeter marking, correct? This has 1 centimeter markings for you to know how far you're from the skin. All right, and when we see the Dura separating Whittaker needle, this is basically these two, the two of them that you see over here. These two are spinal needles. Okay, so these two that you see are not epidural needles. C and D, these are spinal needles, right? Okay, so when you're talking about spinal, the last layer pierced when you're giving spinal anesthesia or when you're doing lumbar puncture, the last layer pierced is the arachnoid, because spinal anesthesia is given in which layer? It is given in the subarachnoid space. Subarachnoid space is what contains the CSF. So when you're talking of layers, guys, remember those layers are very important. So the first layer that you pierce is the skin, then subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. As soon as you cross ligamentum flavum, you come to the epidural space. You cross the epidural space. It's epidural, means outside the dura. You get the dura, then you get the arachnoid. You cross the arachnoid, you reach the CSF, right? So when you are in the CSF, this is what is called as the subarachnoid space. Subarachnoid is where I give the spinal anesthesia. This is the epidural space. This is where I give the epidural anesthesia. It's outside the dura. It's called epidural. Subarachnoid, after the arachnoid. And therefore, this time's INI-CET question, subdural. Subdural is the space between the dura and the arachnoid. All right. So subdural is the space in between the dura and the arachnoid. All right. This is the subdural space. All right. And therefore, spinal anesthesia is given inside the CSF, and in the epidural space is basically what contains fat, it contains blood vessels, it contains nerves, it contains lymphatics. It's a potential space, right? It's a negative pressure space at subatmospheric pressure. The site of action of the nerves are the same. See, the spinal cord is coming over here and the nerves are coming out like this. So therefore, when you're giving a drug in the spinal, the drug covers the nerve right from the root in the CSF. You get a better effect in spinal anesthesia. From here, it gets blocked. But when you're giving an epidural, the epidural is getting blocked in this area. So when you give an epidural, it's possible that the area covered inside the CSF gets spared. And that is why epidural is more commonly used for analgesia. It is not used for anesthesia. We use epidural more for analgesia. And because in spinal, the block takes right from within, we use it more for anesthesia. It's got a better effect. All right. And the last layer pierced before epidural then becomes ligamentum flavum. The last layer before spinal is the arachnoid. So these two questions are again important. So hopefully these points are also clear based on this video. Clear? Fine, guys? Okay. Any questions and doubts you can ask me. Otherwise, we go to the question number 9, I think. We have done 8 questions. This was the 8th one. Yes, we go to question number 9. Okay, which one has the highest complication? In what sense? In terms of the spine. Okay, in terms of this. Yeah, you will have more complications with spinal. More complications take place with spinal. You get more hypotension, more complications with spinal because you are puncturing the dura. Compared to spinal, epidural has relatively less complications. Okay, clear? Okay, so all the things, whether it is hypotension, whatever, high spinal, total spinal, whatever complications you expect are going to be more with the spinal rather than an epidural, right? Because in spinal, you're puncturing the dura. Okay. Next video, just go through this. All right, so you can see something. Right, I'll play this again. There we go. You can see a device. Dr. Shivani Gautam is asking me, sir, is epidural in pregnancy appendicectomy in epidural? It can be done. Dr. Anuj Kumar, you can ask me that question in a while. Let me finish this off. Dr. Anuj Kumar Chaudhary says LMA insertion and IGEL, LMA. Let me ask the question then. Identify the airway device being used in the provided video, right? Is it a oropharyngeal airway? Is it a classic LMA? Is it a ProSeal LMA or it's an IGEL? 9th question. Yes, I think Dr. Anuj Kumar Chaudhary has given one answer, right? Others have mentioned LMA, but what kind of LMA if you think? Is it classic or ProSeal? If you think. Yes, guys. Answers? So as you can see, yes, Dr. Sneha Das, Dr. Med School grad, and everyone else, Dr. Anuj Kumar Chaudhary, correct. The answer, this is IGEL. Why IGEL? Because it does not have a cuff. IGEL is basically a cuff-less LMA. If you will see the procedure, normally what happens, see, all of you know it's not a oropharyngeal airway. Oropharyngeal airway, you cannot ventilate the patient. It is just to prevent the backfall of tongue. When we speak of a oropharyngeal airway, it can be inserted over here and then you can give a bag mask ventilation. But in a oropharyngeal airway, you cannot be attaching the circuit because this is an airway tube. Here is a tube from where I can give IPPV to the patient, right? This is being attached. So oropharyngeal airway will not have this. So therefore, this is supposed to be a laryngeal mask airway, which is fine. All of you have agreed with that. Point is, does it have a cuff? Because when you are going to insert, whether it's a ProSeal LMA or a classic LMA, in all of both of them, if you will see, this device has no cuff. He has just inserted, and after insertion, right, after the insertion, all you have done is connected the circuit onto it and you have started the ventilation. Can you see there is no cuff? There is no cuff to be inflated, and that is exactly the point of iGel. iGel has no cuff. All right, it's called a cuffless LMA. You just insert it and you are done, and that is why it is the most common. So both classic and ProSeal would have a cuff which has to be inflated, and here there is no cuff. Just straight away there was, attached to the IPPV, and therefore this is basically, you can remember it as a cuffless LMA. There is no cuff. You could see there's a straight away insertion. All right. So and Dr. Anuj says it's iGel made up of silicone and self fixation. Self, it goes, and it provides a better seal over there with the silicone which is present. It adapts to the larynx over there. Okay. So therefore, but anyways, I will agree with the fact that ProSeal and iGel both are called second generation LMA. Right. These two are, so classic LMA is basically a first generation LMA, and ProSeal and iGel are basically second generation. So the difference between them is that when you're inserting an iGel, just like a ProSeal, what you can do over here, just like in a ProSeal, what I can do is, once I insert it, I can put a Riles tube from here that goes inside the stomach. All right. From here, I can put a Riles tube that goes inside the stomach, from where I can do a suction. And that is why it's a second generation LMA. All right. And here no cuff has been inflated. You see, just insertion and no cuff has been inflated. All right. Dr. Med School grad says, why not sleeper? No, this is not sleeper. No? This is iGel. This is iGel. It is taking the shape on its own. Yes, there are many airway devices which are of that way. Correct. There are many airway devices which come. But this is what you guys are supposed to know as of now. Just think about it. Okay. So as you can see, this is the first place from where I can give IPPV to the patient. Okay, from here the patient can get IPPV, and here I can put a Riles tube that goes inside the stomach, from where I can do a suction. And therefore the point is, because there is one tube and there is two tube, this becomes a second generation LMA. The important point is there is no cuff. He has not inflated any cuff over here. All right. So therefore, when we speak of the LMAs, all of you know the classification that basically there are two types. We have a first generation LMA and a second generation LMA. The second generation LMA is basically of two tubes. First generation just has one tube. Second generation has two tubes, right? The advantage is that in second generation LMA, because of the second tube, which is a drain tube, I can insert a Riles tube in the stomach, from where I can do a suction. And after that, therefore, we can use it for IPPV in anesthesia. What happens is, the second generation LMA decreases the chances of aspiration. Does not prevent it, but it decreases the chances of aspiration. Because the drain tube is present, it decreases the chances of aspiration. On the other hand, the first generation LMA, right, it has high chance of aspiration. So in anesthesia, it is used only for a spontaneously breathing patient. That is the difference. Now, when you speak about the first generation and the second generation, remember the first generation LMAs are basically the classic LMA, the intubating LMA. All right. Then you have flexible LMA. You have unique LMA, single use. Flexible is like the flexometallic tube. In fact, even that Ambu Aura 40 that has been asked in INI-CET exam last year, that is first generation. In fact, all Ambu LMAs except for one are first generation. All Ambu LMAs except for one, and that one I'll write here. So second generation LMA, there is ProSeal LMA, there is Supreme LMA. All right, there is iGel, cuffless LMA. This was the cuffless, and the Ambu. This is Ambu Aura Gain. This is the only Ambu LMA which is second generation. Rest all are first generation Ambu LMAs. Clear? So these are the first and second generation LMA devices. Let's go to the next one. The last question. This you can see is a procedure being done. All of you as interns and post interns must have done this many a times, right? When you're there in the wards, in the casualty, you must have done this many a times. All right. So just go through the procedure. You're seeing an emergency procedure being done on a patient. Emergency technique. All right. So you can see it. I'll play the video again. You know what is happening. All right, so let me ask you the question based on the procedure now, all the video that you've seen. Right, so this emergency technique is being performed in the video. It is done in which of the following conditions? Patient is unresponsive, breath absent, pulse present. Patient is unresponsive, breath and pulse absent. Patient has choking and is responsive. Patient is unresponsive, breath and pulse present. Yes. So this will be the last question for today in video. These were the video based questions. As you saw, length and breadth of anesthesia. Let me play the video again. You can see this. This is the question based on this. So we have covered all topics from anesthesia, guys. Okay. Dr. Ankit Mahajan says CPR. Correct. But what is the answer? Yeah. So Dr. Med School grad and Dr. KKB, Dr. Vidyanand has given an answer, right? Dr. Gaurav, Dr. Ankit Mahajan, yes, everyone has given the answer and all of you are absolutely correct. A similar question has been asked in the PYQ. Here the answer is patient is unresponsive, breath and pulse absent. Rest, I'm very sure that you would be knowing that when the patient is unresponsive and breath and pulse are present, this question has been asked as a PYQ. You keep the patient in the recovery position and monitor the patient. Am I right? This is what you do. When this question, patient is unresponsive, breath absent, pulse present, this was asked this time in INI-CET. When they were said that you are supposed to have an unresponsive patient where you had to give naloxone for reversal, if you remember. This was the question asked this time around in INI-CET. Naloxone, the question on naloxone, unresponsive patient who's an IV drug abuser. All right. So here, breath absent, pulse present, you can give naloxone if there are signs of opioid toxicity. And if breath is absent, you need to give breaths to the patient. Give 10 breaths per minute. You have seen that. And check pulse every 2 minutes. This is the point. Now, when the patient has choking and the patient is responsive, remember the new guidelines say these are abdominal thrust followed by back slaps. Even in adult. Yes, abdominal thrust is what is called as abdominal thrust. Plus back slaps are given. Remember, nowadays it's not just the Heimlich maneuver that they say. Remember this point, guys. Okay. If I will just show you once again, if I can just show you the new guideline. I'm not very sure as to how many of you have seen this, but just give me a second. So these are the ones which are the guidelines nowadays. I'll just show you. No, not this one. Just give me a second. You will find that, choking. Wait, let me just change it. So just give me 1 second, guys. This is the CPR guidelines and these are all the CPR guidelines, guys. And where's choking gone? Drowning. Because that's an important one. I'm not getting it. 1 second, 1 second. Bradycardia, child. Just 1 second, guys. Right. So this, if you can see, is this exactly. Can you see this now? This is about an adult. Can you see this? Foreign body obstruction. These are the absolutely new guidelines. And you can see over here that it is 5 back slaps and 5 abdominal thrust. This is what is said as the new guideline, guys. Okay. 5 back slaps and 5 abdominal thrust. These are the new guidelines from the American Heart Association. It is not just about the Heimlich's maneuver or abdominal thrust. Yes, abdominal thrust is a Heimlich's maneuver. And the star has been marked because they say that in case the patient is pregnant, right? If there's a pregnant lady, in this case, you're supposed to give the chest compression. If you can see, these are the 2025 guidelines from the American Heart Association, right? And this is what is when it's not about Heimlich's maneuver and abdominal thrust anymore. It is 5 back blows or back slaps followed by 5 abdominal thrust. Clear, guys? So remember, these are the changes that have taken in the guidelines. Okay, so this is the 2025 guideline. So I just wanted to show this to you. All right. So going back to what we were discussing. Okay, guys. Clear? Now, so here when a patient has choking, so choking nowadays is not just about if there is choking. This question has been asked many times. And remember, if the choking patient is responsive. So even for adult or for pediatric, remember one thing, there has to be, in a pediatric, it is chest thrust in less than 1 year, but otherwise it's abdominal thrust and back slaps. This abdominal thrust can be said to be the same thing as, Heimlich's maneuver. But in choking, if the patient is unresponsive, the first thing is to start chest compression. Don't remove the foreign body here itself. No, they have not said that. Don't remove the foreign body here. Give a chest compression and then you check for the airway. When you are checking for the airway after giving chest compression, here if you find you remove the foreign body and after that you give breath to the patient, it's the same thing as CAB. So when you're going to give breath, remove the foreign body before that. So unresponsive patient, we will give chest compression followed by airway, remove the foreign body and then give breath. For responsive patient, abdominal thrust and back slap. If it's an infant or a pregnant lady, I'll be giving a chest thrust followed by back slaps. Clear, guys? So these are the new guidelines for choking. Rest everything else remains the same, right? These are the 2025 guidelines. So we have seen this image also, this video as well. So that is from me, guys. So it's my Instagram ID. I have my WhatsApp number to you. Any questions and doubts you can ask me. Otherwise, we finished our questions. There were 10 videos that we discussed. Hopefully, this must have been of some use to you. You must have understood what kind of questions can be asked. If they are asked from video-based questions, they are going to be easy. Only thing is that you have to apply your mind and concentrate on the video. I don't think they're going to ask you difficult questions if it is from anesthesia. Even the question which was from the, FMGE, it was the Mallampati question that was asked. Simple, Mallampati 1 was asked. I made it much difficult by giving Mallampati 2, the video. But otherwise, Mallampati 1 was a simple question, right, which was asked for FMG. Thank you, guys. Any questions and doubts, you can ask me, right? Otherwise, I've shared my number. I've shared the Instagram ID. Any questions and doubts, you can ask me. You can follow me on Instagram. You can ask me questions on Instagram as well. Okay. I respond to the best of my ability when I get time. Okay, guys. Any questions? Otherwise, I'll take your leave. Thank you for joining me at this session. Thank you. Thank you, Dr. Gaurav. Thank you, Dr. Anuj. Thank you. All right. So no other questions otherwise from anesthesia. So all the best, guys. Do well. And when you secure your rank, let us know. We like to get messages from you guys. All right. So whenever you secure a rank, do let us know in the message box. Right. You can message anywhere on the Instagram, on the number or wherever. But let us know that you've secured your seat. All right. So all the best and do well. Bye-bye. Good night.